Okay, foundations, let's do this thing. We're going to go through all of the bullet points that you guys gave me. I will go through the slides and let you know what I find. For all my other friends that are listening in for my Exit HESI or for capstone class, same thing. Welcome. Pay attention. It's been a while since you guys have probably gone over this. Foundations and health assessment are going to be about 65 to 70% of your Exit HESI and your NCLEX. So this is very important, this information that we're going to go over. So get a notebook, a pen, and kick back and let me get through these 15 slides, all right? All right, so I'm going to get my little pen light. Cool. So when we talk about nutrition is going to entail blood glucose monitoring for sure. Specific to blood glucose monitoring, how often do we monitor blood glucose levels if it's ACHS? What does ACHS mean? Blood glucose, are we going to do it, how much prior to eating meals or after to eating meals are we going to check blood glucose levels? So we would normally do it prior, obviously, because if you do it post, it's silly because they've already eaten. So we need to know the signs and symptoms of someone with hypoglycemia and hyperglycemia. I always tell everyone cold and clammy needs some candy. So those are the signs and symptoms if they're hypoglycemic. So make sure that you're studying hyper. Make sure that you're studying blood glucose levels, like what is an appropriate level, what is an inappropriate level. How soon before you would do an AccuCheck or check a blood glucose level. What do you need to consider in blood glucose monitoring related to exercise? How many more carbs do you need to introduce if you are starting an exercise regimen and you are a diabetic? These are all questions that come up related to nutrition, related to blood glucose monitoring. Let's see, what else would be something that we would consider from a foundations perspective. I think that's about what they give you for blood glucose. Let's see what else is in here. Enteral or parenteral nutrition. First, you need to know what it is. And then you need to know precautions related to it. You need to know enteral and parenteral nutrition. You need to know signs and symptoms of something going wrong. What would we do to need to get on it? And what would we need to do to get off of it? All right, that's usually what we get with that. Food safety. We need to know about safe handling of food and cross-contamination. So usually when we get food safety questions, they're usually weird ones related to cross-contamination of serving someone a breakfast tray or a lunch tray, and that patient needing a wound, cleaned or changed. And usually what you want to know regarding that is you don't want to cross-contaminate. You want to wash your hands in between. That usually comes up a lot. BMI. Things related to BMI. You need to know how to do the calculation for BMI. I can almost tell you, proof positive, that they are going to ask you how to calculate a BMI. They're going to tell you about Sally, who sells seashells by the seashore, that is such and such pounds and is such and such height, and you need to calculate where they fall into the spectrum. Vegetarian diet. What does a vegetarian eat versus an ovo-vegetarian versus someone who is on a purine diet versus someone who is on a low potassium diet? You need to know what that means. Low potassium comes up a lot too. So a patient who's on spirulactone, what foods do you need to keep into consideration while the patient's taking this medication? Well, spirulactone is a potassium-sparing medication versus Lasix, which is a potassium-wasting. So you would want to stay away from foods high in potassium. So what foods are high in potassium, right? That type of a deal. Daily dietary recommendations. That usually includes cardiac 2-gram diets. They want you to know what is the actual grams of sodium that you can have for cardiac diets. Diabetic diet, they want you to know what that consideration looks like as well. Usually it's a 60 gram, but they can bump it up to a 75. Let's see, characteristics of urine. You need to know what color urine means what type of disease process. If it's Coca-Cola colored, it usually is related to liver failure. If you have crystal clear urine, how much solute to solution are you going to have? How much salt are you going to have to the water that makes your normal saline? And I know that I didn't say that right, but that's cool. I'm just trying to make an observation here. You need to know what the ratio of salt to fluid is, because you need to know if this person is hypo or hypernatremic. Or natremic, yeah. Education for healthier bladder. How can we teach somebody bladder training, right? Urinary specimen collection, you need to know what a clean catch looks like, and how we explain to somebody what a clean catch is, and what a specimen looks like for a culture and sensitivity, and what that procedure is. Going back to characteristics of urine, you need to know why someone would have blood in the urine, what that could mean, why someone would have neon green urine, why someone would have blue urine potentially, while if someone you would have orange inky urine. All right, so I would just go to that section and just look up all those things respectful and related to that urinary elimination. So education for a healthy bladder, that is bladder training. So, doing your exercises, making sure that you take yourself to the bathroom, making sure that you don't drink a whole bunch before you go to bed so that you don't wet the bed, things of that nature. So let's see, bowel elimination, fecal characteristics. Okay, so what does really dark poo mean versus, really white, almost ghost-like color poo mean, right? What is diarrhea presume versus, severe constipation? What are some things that we need to tell a person if they have severe constipation? Well, obviously, we need to tell them that they need to increase their fluid intake, and they need to have a certain type of fiber added, right? Why we should not use stimulant laxatives, that's always a question, is making sure that you understand that by, usually it's by way of a question that says, patient comes in with frequent use of stimulant laxatives, states they need another one, hasn't had a bowel movement in 4 days. What should we do for the patient? And we should re-educate the patient the use of stimulant laxatives can cause rebound constipation if used chronically, that type of a deal. That's usually how that's worded. Bowel training and retraining, again, what does that mean? That means making sure that you go for a walk, but you stop to go to the bathroom, or that you go to the bathroom 45 minutes after you consume food. Look at what that bowel training and retraining looks like. So ostomies, these are the hot points. What is the stoma supposed to look like? What does the stoma mean when it's not right? So you need to know difference between stoma good versus stoma bad. It usually comes in the form of which one of these observations of the ileostomy by the nurse reflects the need to consult with a physician immediately. And you would look and note the one that says that the stoma is purplish black, because that would indicate that it's dead or dying, and that we don't have blood flow adequately there. And then a normal finding would be, it's pink and beefy and red and all of those things, and that is working effectively. So sensory alterations, common visual deficits. So these are the big five: glaucoma, macular degeneration, retinal detachment, always retinal detachment, because that's your emergency where they see the flashing lightning bolts. Cataracts. And you need with glaucoma, open angle versus closed angle. Which one is the emergency? Cataracts, strabismus and diplopia usually come up. And I feel like those are macular degeneration, glaucoma, strabismus, diplopia, open angle, closed angle glaucoma, cataracts, retinal detachment. I swear I think that's it. As long as you know those, and specifically what causes it, what medication do you need to use for it. With retinal detachment, know the signs and symptoms and know the time that you have to get to the hospital. When you're talking about glaucoma, open angle or closed angle, you need to know what the level of pressure is considered glaucoma. You need to know which one is the scarier, opened or closed-ended, or closed angle. I don't know why I want to keep saying open-ended. So open angle versus closed angle. Cataracts, they want to know, with macular degeneration and cataracts, they want to know what direction the vision loss comes from. So is the vision loss on the outside, but you can see the inside, or is it blurry on the inside and you can only see the outside? You need to know the difference between the two. So I would look up the difference between a cataract and a macular degeneration. And that is usually what is covered under those things. Common hearing deficits. Let's see. Common hearing deficits. There is neurosensory hearing loss. You need to know what causes neurosensory hearing loss. I'll give you a hint. It's aging. You need to know what the deficits are related to neurosensory hearing loss. So the frequency. High frequencies are going to be a normal deficit in the aging individual. And we also need to know about the other hearing deficits. Let's see, Meniere's disease is a good one. So I would want to know what the signs and symptoms of Meniere's disease is. I would want to know those things related to neurosensory hearing loss as well. They talk a lot about inner or middle ear infections in swimmer's ear relating to hearing loss or hearing distortion. So I would want to know, again, what causes it, what cures it, what are the signs and symptoms of it. And that usually gives you some good basis to cover. And what helps the swimmer's ear is usually another one, because swimmer's ears are different than a middle ear infection, just a little bit. Also, a perforation of the eardrum. What are the signs and symptoms? Usually a perforation of your eardrum means you have incredible amounts of pain, followed by relief of the pain, pressure, and a bunch of discharge exiting your ear. And that is from the pressure of, whatever that fluid is, pushing against the eardrum and finally popping a hole in it and then exiting out. That's usually on there quite often. Factors that affect sensory function. So these are cranial nerve deficits. So cochlear nerve 8, cranial nerve 8, vestibular cochlear, however you want to put it. That one usually is related to balance and gait. So they usually ask you about tests related to testing for balance and gait. And what you have them do is close their eyes and lift one leg. And if they fall, or they have anything above, a general sway, that is considered a positive finding. You need to know the name of that test, more than likely. And then nursing interventions for sensory alteration. So what do we need to do when someone has a deficit of vision? What if they have macular degeneration? A good question is, a patient has macular degeneration, how do you serve them their food? Right? So you need to know that you need to turn the plate once they finish it. How would we navigate letting a person know what's on their tray if they're totally blind. We would tell them the drinks are always going to be served at this location. You know, the top left-hand corner, your fork and spoon's always going to be at this location, da 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 da. And then you keep that for continuity of care for the patient. Continuity of care is we keep doing the same thing over and over so that the patient knows what to expect and they have a better level of control within them and a better level of health and well-being overall based off of our intervention and us keeping the same intervention the same way, if that makes any sense. So self-concept, Erickson's stages of self-concept. You need to know the stages. They're going to flat out ask you what the stage is. They're going to flat out talk to you about someone who is working with, you know, this type of situation, which relates to this stage. And then it's going to say, what is the stage before that? Or what is the stage after that? Or we know that, you know, Sally who sells seashells by the seashore is now in this stage as they have just passed this stage. So you need to know those stages. Factors affecting self-concept. Lots of factors affect self-concept. Your cultural narrative, your environmental narrative, right? Your cultural narrative means how your culture establishes your way of thinking about the world around you and your way of understanding diversity, your way of understanding your creator and how that relates to you and your ability to function throughout life. I mean, it's kind of a big deal. So we need to know what a dysfunction of that self-concept means, because that will come up as well. Role performance stressors. Again, under self-concept, that's going to have a lot of variance. If I were you, what I would do is I would go to the index, which is the back of your book, and I would look up self-concept, or I would look into that chapter. I would look up self-concept. I would look up performance stressors. I would look up altered self-concept. And then I would go to those pages and just read those couple of pages and understand that information. These questions, spiritual distress, things of that nature, nursing interventions for spiritual distress, these are always related to stages of grief. How do we handle a gentleman that just found out, you know, he's got terminal cancer? And he is pointed and he's not talking, you know, how do we speak to them and approach them? So they're going to give you a bunch of statements that a nurse would make related to a patient scenario, and it's usually related to a grief experience. And then they will ask you either what stage of grief it is, and they will give you an indicator, like patient states, I don't believe that I have breast cancer. I'm going to go get a second opinion. Well, that's denial, right? Versus, I don't know what I can do, doc. If I get treatment, can I live another 10 years? That would be an example of bargaining. So you need to know a lot of times what those stages look like of grief and what the patient is doing about that grief and what stage of grief they're in. Or you'll need to know how to respond to that patient that is explosive because they just found out that they're sick. So don't find the answer that's going to make you look like a jerk, and the answer that sounds reasonable is usually the true, correct answer, okay? When it comes to spiritual health questions and they give you these scenarios and these options, I always do myself a favor. And when they give you these phrases that we have to respond to our patient with, I say them out loud in my head, and I picture the most grotesque goblin telling me this, because to me, a goblin is kind of funny, but also kind of scary, right? Like, what was the movie with the little white furry thing that couldn't drink after 8 o'clock or it would turn bad? Gremlins. Yes, I would think of a gremlin, right? Because it could be either good or bad. And have them say that sentence in your head. And if you hear that sentence and you don't get offended by that sentence, that's generally your right answer. I know it sounds weird. It just makes it easier for me with, you know, what I have going on. Because a lot of times words don't really articulate something. I have to physically watch a person say it, and I have to hear it. And hear, you know, its tone. Is it pointed? Is it relaxed, right? I can't I can't just look at words and determine if that's correct or incorrect, decent or not decent, until I hear it in my head and I see it from somebody. So use that if you struggle with that as well. It might help. Math conversions on a fundamental level or foundations level, it's usually going to be related to patient had medication and can only afford 30% of that medication. The patient's medication's for 90 pills. How much is 30% of 90 pills? That type of a deal. Also, at this level, they will ask you, Sally who sells seashells by the seashore has medication which has been reconstituted to liquid form. 5 milliliters equals, 100 milligrams. If they had 10 milliliters, how many milligrams would that be? Right? That would be another one that usually shows up often. Calculate intake. So this is going to be something interesting. You're going to need to know how many milliliters are in a liter, right? And that should be a pretty easy conversion. How many ounces, how many milliliters are in an ounce? Because what they're going to say is, Sally who sells seashells by the seashore, with your calculate intake, she came to the hospital with intractable vomiting and has had the following to drink. She was able to drink down a 4-ounce soda, so how many milliliters is that? Plus she had a Jello, which was 4 ounces, and then she peed 200 milliliters. What is your net gain or loss, right? So how much is she is she even, Steven? Is she at a gain or a loss of fluid, right? So we're checking to see if she's fluid volume depleted. That's usually how that goes. So make sure that you understand those conversions. Also know your quarts and your pints, because that one always seems to come up and it's really annoying. Like they'll say something along the lines of they had a quart of lemonade or something, or their family brought a quart of tea from home or something stupid. So just to make sure you understand those conversions as well. Calculate total dose over time. You can YouTube that. Calculate single dose, same deal. Just give it a YouTube or a Google. Watch the 5-minute short on that, and that should make that a little bit easier, because I don't have the ability to, write down the math for you. So that would be my suggestion. And that would be how I would start studying for these. If you haven't already, I'm sure you guys have, because you've had to study to do this. So let's look at to the next slide, and I will try to break this down even faster. All right. Here is what I have learned about these slides. So I know they're just a bunch of tables, and I get that. But these tables are important. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. Hang on. All right. So I want you to do me a favor. I want you to look at these tables and look at what it is that they're trying to tell you. The tables are meant to be an added resource to teach you in another visual spatial way, to break down the words faster, so that as you're understanding these concepts, you can then break it down for a couple of words. Will show you where you need to go and what that's related to. I hope that made sense. So as you're studying with me, I want you to go through these tables, and I want you to look at them again. And yes, I do want you to go through all of the tables if you have time, because things like spirituality, and review page 769 and review the box and look at the assessment questions. I would look at them because it is probably related to the point that I made earlier, that these assessment questions are going to give you a stack of them, and you have to pick the most appropriate one based off of what's going on with your patient. So I would look at them because it's probably going to give you a table of appropriate questions and inappropriate questions, and I bet you anything that one of your questions might actually be on there. If I had to be a betting woman, I'd say that that was probably a thing. So pay attention to your tables. Your tables are going to help you break things down even easier as you were narrowing ways to understand these concepts from a very simplistic point of view. All right, so go to the next slide. All right, so Abby and Grace, this slide was on bowel elimination. So bowel elimination kind of goes into many different directions. Bowel elimination can include how do I educate my patient regarding constipation? Knowing the most common things related to bowel elimination, which is usually constipation, diarrhea is another one. So you need to know what can happen to a patient related to constipation versus diarrhea. We need to know what we would educate them and include them on related to constipation versus diarrhea, right? What is the recommendation related to fiber for constipation versus diarrhea? Or for someone who, what do we need to do with fiber if they have Crohn's or colitis? What does that fiber requirement look like? That's usually on there. Surgery and anesthesia, a paralytic ileus. So what does that look like? What is a paralytic ileus? Where it's an area of your intestines that stops that activity called peristalsis, which is where it's kind of moving things along against the pipeline, right? So what are the signs and symptoms of a paralytic ileus? Well, very simply put, you're not going to have any bowel sounds in the quadrant, right? And then how long do you have to listen to bowel sounds? Usually it's 5 minutes per quadrant. So the answer might be something related to, something is wrong with the patient. Patient keeps vomiting. It has a light brown foul smell. What might be wrong with the patient, or how would we assess this patient to see if it were a paralytic ileus? And we would listen to all 4 quadrants for 5 minutes. Or what would be an indicator for a paralytic ileus? And we'd have to look for the patient who has an observation during that time of having no bowel sounds after a 5-minute listening period, right? They'll flip the question in 5 and 6 different ways. But the information that they want you to have known for knowledge base for the sake of that question is very simple. And it's just one simple concept. But you need to focus more on how is it that you know what it is that they're asking for. I think I need to do a slideshow on that. I think I need to do a slideshow where I narrate every single question and I go through it with you as if we're doing a class together, like an Exit HESI class, because I think that would help everybody understand these types of questions. If you do want that, or if you think that would be a good idea, send me a text message and let me know. I would do the like, share, and subscribe, and, leave a comment. I just don't care. I honestly, you're never going to hear me beg for that. That's crazy. But for the purposes of getting with me so that I can give you good quality material, just text me and let me know what it is that you need, because I'm going to give it to you whenever I find the time to get it done in. And if it's something I know everyone's going to benefit from, I'm going to take the time to do it. I don't care what day it's on. I mean, it's Sunday right now and I'm talking, so don't feel like you're getting in my way. Help me foster your learning and development. I want you guys to be solidly great nurses. So tell me what it is that you need. Fecal occult testing. Know what that is. Know that you can do one at home. Know that it is a good indicator for determining cancer. Know how old you have to be to start doing these tests. Know why we would do one. So a patient who has a history in their family of colorectal cancer and they have polyps. Well, I don't care if they're 21 years old. I'm doing a fecal occult on this person. I'm doing a occult test to see, since they have a history of polyps, since they have this history, I'm going to give them more frequent colonoscopies, and if they are giving me indicator for having any type of bleeding, like they've complained about, blood in the stool, I'm going to do a fecal occult test. So know what that means and know that blue is positive. And that is probably going to be a question on your test if I had to be a betting woman, is how to diagnose hidden blood to help with the diagnosis of colon cancer. And it's going to be a positive blue check mark in the window after you have activated it with the serum to confirm a fecal occult test is positive and that there's presence of blood. All right, so bowel diversion, ostomies, yes. Ileostomy. I love how he put liquid output because this is going to be the first thing that always shows up. All right, so ileostomy is going to be more liquid. colonoscopy, depending on where the colonostomy is. Yikes, colostomy. That's the word I was looking for. Where the ileostomy versus where the colostomy is depends on what type of liquid versus hard. The higher up it is, the harder the stool's going to be because it hasn't been able to get all of the nutrients pulled from the villi and the microvilli, those little fingers that are on the inside of the intestinal lining that grab all the nutrients and absorb it. So if you're higher up, it's going to be more solidly formed. If it's lower down, it's going to be more liquid formed. If it's higher up, it's going to be stinkier versus if it's lower down, right? Because remember, those minerals, as they are passing through and become more liquid, there's not a lot of mineral left, right? So it just, the experience is going to be different. So related to this, it's usually a question about educating your patient and letting them know that it's normal for their new ileostomy to be liquid because that would be the expected finding. That's usually how we ask that. Help promotion of normal defecation. Cool. So yeah, screening starts at age 50, or if you have a history of colorectal cancer in the family with a history of polyps, you would do it far more frequently, right? Because they have an increased risk. Promotion of normal defecation. So if someone's constipated, how much fluids do I increase in the diet, and what's that recommendation look like? And no use of stimulant laxatives. What type of bulk forming fiber do we need versus other derivatives of fiber? I think that is it. What kind of bowel sounds would I expect if someone hasn't had a bowel movement in 3 days? Hypoactive. Yeah, so that should cover those bases. Let's see. Laxatives. Bulk forming, best for chronic constipation. Good. But not stimulant laxatives. High fiber diet, fluid, exercise, stool softeners, and lubricants. Perfect. I love all of those answers. All of those points of contingency are going to be a potential for being put together. Again, make sure no stimulant laxatives. That always comes up on a question. High fiber diet always comes up in a question. It's going to ask you to pick some things that are high in fiber, so you're going to have to know what are the high fiber sources. Yeah. That should be good enough. Next slide. Okay. So bowel elimination and enema placement. So again, they're going to ask you what your position for an enema is going to be. Your position for an enema is going to be the Sims position. And I am actually texting a source to make sure that that is correct. So first off, the Sims position is going to be the person lying on the left side. The left hip and the lower extremity is straight, and the right hip and the knee is bent. So I call the Sims position the murder position, right? So they're always the ones where they're the crime scene photo position. They're the ones that are the chalk outline, and they're all like kind of laying cattywampus. Okay, so that's Sims. And that's usually the one that they require you to do while you're having an enema put in. Remember, the sigmoid colon, we always want them on the left side, turned towards the left, because that's when that S is easily bypassable, which is super important. Stress and anxiety increases bowel elimination, diarrhea. Yeah, so we need to know what the difference is between Crohn's and colitis versus irritable bowel syndrome versus regular diarrhea. Those are going to come up. And usually it's related to timing. So a person who has had chronic bouts of constipation followed by chronic bouts of diarrhea, and then it says something about and has recent anxiety in the last few months related to losing a job or something stupid. That's going to be irritable bowel syndrome versus a Crohn's or colitis versus a acute episode of diarrhea, right? So you need to know what the difference in those types of bowel elimination are. What does Crohn's mean? What does colitis mean? Which one of these is going to result in a potential for an ileostomy or colostomy or geniostomy or anything of that nature? Which one is an infectious process and which one has the harsher signs and symptoms? Maybe even what is the medication to kill it, but I doubt that we're going to go that far on this level. But mostly it's about identification at this point. All right. Laxatives, antidiarrheal agents, yes, know those things. Usually it stays at like Imodium, polyethylene glycol, or what they call Miralax. It's usually 17 grams. How to position the patient in bed and the medications related to it. Very good. So what are the types of medications that we use? We'll use Colace. Like I said, we'll use Miralax. We're going to use types of fibers. We need to know what type of fiber we're going to use. And the position in the bed is usually left lateral position into dorsal recumbent. Dorsal recumbent is just the supine position on the bedpan. That makes sense, yeah. So know your position. If you see an option for Sims, I would pick that before left lateral positioning because that has always been the answer. But if they just give you an option of left lateral, that's fine too, because left lateral is part of the Sims position. And signs and symptoms of constipation, yep. We need to know all of those things. What does the skin look like as well related to constipation? Are they nauseous? Are they vomiting? What does that mean? Those are important. Signs and symptoms of dehydration. Yeah, again, skin turgor, dark urine, dry, fatigued, lightheaded, thready pulse, right? Those type of deals. And then for infants, no tears, no wet diapers for 3 hours or more. Listless is a big word here. Listless is a big word. They're going to tell you about a patient, and they're going to tell you that they have sunken eyes. They're going to tell you they have soft spots in the skull. They're going to tell you they have dry mouth and tongue, and then it's going to ask you about their level of cognition, what to expect. They're going to be listless or irritable. You need to know those things. That's how the question is going to be asked. At least that's been my experience in any NCLEX, Exit HESI, or any other standardized examination. They want you to be able to put together babies who are dehydrated, have no tears, have no wet diapers, they're listless, they're irritable. Please know that. If you don't know what listless is, look up the word listless. It means you're just kind of laying there like a bump on a log. And you're just kind of barely there, barely cognizant, barely responding to any stimuli around you. You're just a zombie, basically. So let's go to the next slide. Okay. So when we're dealing with constipation, diarrhea, and indigestion, here's what we come up with. We need to find out when the last bowel movement is. If it's been 4 days versus 20 days, that's going to be a difference in condition for the patient. All right, so that's why we ask. If we have to strain, that could be a big problem. Sorry, I just choked on a gummy bear, kind of. That could be a big problem because if we've got someone with a aneurysm in their abdomen and they're straining because they're constipated, we're going to help blow that bad boy up, aren't we? So these are how we have to kind of look at things. When it comes to diarrhea, we need to know how long has it been going on? How many bouts of diarrhea have you had? Do we need to get a C. diff specimen? You're going to have a patient that's going to be, 3 or 4 days into diarrhea, and it's going to say, and has recently started a new antibiotic. You know that we need to do C. diff testing at that point, right then and there. We have to get the stool sample before we can give them Imodium. That's also a problem. That's also a common question that pops up. Indigestion. You want to know what time of day? Is it right after a meal? If it is, we need to give a proton pump inhibitor. It's more than likely GERD. What are the signs and symptoms of GERD? You need to know that. What foods to stay away from a GERD? That's also a question. And that question is usually in the form of, Sally, who sells seashells by the seashore, has been recently taken a medication to help with her gastrointestinal reflux issue. And also, education would include remembering to decrease the limit of blank you intake, right? And we would say things like foods containing marinara sauce, right? Because that's the big problem that helps increase the acidity. Also, you staying away from milk, because milk also messes with the idea of a hormone. There's two hormones in your that get sent down to let you know if you're hungry or not. One is leptin, which means leave me alone, I've had enough to eat. And then ghrelin means if I'm ghrelin, I'm growling and I'm hungry. So if you are drinking milk, it increases the hormone dump of ghrelin, which then increases the level of acidity. So it actually does the opposite of what people think it does. And that's another thing you need to know, right? To stay away from those type of substances, because milk is terrible for it. Constipation, again, same stuff. How long has it been? Signs and symptoms of a paralytic ileus related to constipation. So I'll know that they're going to have abdominal pain, inability to have a bowel movement. They're going to strain. I need to know what medications to give. Usually it's going to be not anything but a stimulant laxative. A question actually tells you to educate the patient on determining or deterring from the use of stimulant laxatives that I've seen in the past. Also, when we're talking about history of GI problems and surgeries, if someone has, a bariatric surgery, we know that they have a higher rate of constipation because they can't eat and drink as much, right? Let's see. Sorry, I'm chowing down on gummy bears. Are really good. That should be it. Again, know your signs and symptoms of indigestion, diarrhea. Know we're related to diarrhea. You have to get a C. diff specimen if it's acute and they've been using antibiotics. Know that you have to have the specimen before you give them Imodium. Indigestion. Know what indigestion looks like. Ask them about radiation to shoulders or the arms. That's a big deal too. Because that will also let us know what that looks like. Is it myocardial infarct? Is it more GERD? Yes. How does the emesis look and what color? Mucus, blood, indigestion, or food? This is going to let us know as well if we're dealing with a bleeding ulcer, right? So it's going to say coffee emesis type of a deal related to a bleeding ulcer. And then you need to know what's the medication that we would use prior to the patient eating for that. And I don't know if you guys get that far, but a lot of times it's Carafate to coat it and then a PPI to lower the acidity. So like a Protonix or so. It's usually pretty good. And it's 30 minutes prior to each meal would be the Carafate dose. It's usually a liquid substitute or reconstitution, or it could be a pill. I think that's it related to these things. Just know the scenarios, know what you have to do to protect them in the event of them having these types of issues. Know what an MI is going to look like versus traditional GERD. That usually is a question because we have so many patients that come in with not otherwise specified chest pain, which could also include GI upset, which could also be both MI or GERD, all of those things, versus a hiatal hernia even. So let's go to the next slide. Okay, so this slide is going to be related to bowel retaining and the idea of assessment, diagnosis, planning, implementation, and evaluation. For this question, I can probably bet you a Red Bull, no carb. This question is going to be related to one of these principles. And it's probably going to be related to the idea of implementation. And let's talk about why. Implementation is the area, when we're talking about these 5 principles, it is the area that most people nationwide mess up on their NCLEX. So they have decided to make implementation what we focus on, which is funny because I'm implementing a principle right now, about implementation. So in implementation, This is the point where we put interventions into action. Prior to that, we don't. At the implementation phase, which means implementing, which means putting things in action, we put interventions into action. Now, I know that is gravity shaking, that concept that I just threw out there. That during implementing, we put things into action, like implementing a performance improvement plan or implementing a, I don't know, slideshow discussing points of contingency for a blueprint of an examination, perhaps. Okay? So know the phases and know in those phases what that means. Because it's going to say the nurse understands that during, the blank phase, this happens and this happens as well. So that's all you need to know about that. And it's probably going to be one question and then you'll be done. Next slide. Okay. I don't know if we're going to be going as far into allergies and iodine and these pylograms and what that's going to ruin as far as your body system's concerned, but we need to talk about it regardless. Because this is always going to be a question on your NCLEX, always going to be a question on your exit HESI, always going to be a question on your standardized tests, and I don't know if this is going to be the one, but it might be, so let's get into it. When we're talking about kidneys, you always have to worry about your creatinine, because your creatinine is important. It lets you know how toxic your kidneys are. Okay? GFR is your glomerular filtration rate. That is another one that you will constantly hear about. You're going to need to know this for the bigger test. Probably not this one. But you definitely need to know that if someone has an allergy or any type of IV dye that is going to go into this patient and they have an allergy to shellfish or iodine, they cannot do it without a prep. And you don't need to know the prep. I'm pretty sure the prep isn't there because the prep is something that we have individually. Usually it's a B52. A B52 for us is a really nice shot of Benadryl cocktailed with, something that has a relaxing component to it, like an Atarax or an Ativan, depending on what's going on with the patient and if they're really having a hard time, with a small dose of something else. It doesn't matter at this point. Or we'll give them just straight Benadryl, and we'll do it, 2 hours prior to the examination, then 1 hour prior, right? Like that type of a deal. It just depends on who you have and what the circumstance is and what the test is. But the bottom line is anytime we give someone injectable dye, it is going to blow our kidneys more. Okay? So I have to watch my creatinine levels, because if my creatinine levels get too high, I have to be dialyzed, which means my kidneys are so toxic, they're nearly non-functioning. Okay? So, you are absolutely going to get a question. First off, an IV pyelogram, it's a study. It's a study, it's like an x-ray exam. They inject contrast material to look at the kidneys, look at the ureters, look at the bladder, help diagnose any blood in the urine or pain in your lower back, things of that nature, right? But it involves contrast again. So the big take home with contrast is it's going to blow your kidneys. You have to watch your creatinine. And if you have an allergy to shellfish or iodine or anything of that nature, you cannot have contrast without a prep. And that's all you need to know about that. Now, NANDA. Oh gosh. What in the world would you need to know about NANDA related to the kidneys? How in the world am I supposed to know that? Basically, they want you to know about the most frequent care plans related to nursing diagnosis, related to readiness for enhanced urinary elimination. Okay? So, what does that mean to have readiness for enhanced urinary elimination? Well, that means that the patient is prepared mentally to have a better outcome related to their ability to urinate. Why is that important? Well, it's important because if my patient isn't ready to go there and isn't ready to deal with that diagnosis and isn't ready to deal with that education I'm about to give them, why am I there? Okay. So if I had to guess, the question is going to be related to a patient that is not ready for enhanced urinary elimination and is avoidant, or perhaps non-compliant. So you need to know that that means a patient with those symptoms and that kind of attitude and presentation is going to mean that they have a readiness or a non-readiness for enhanced urinary elimination. How about that? Maybe we're perhaps talking about the inclusion of the patient getting a TURP procedure related to a prostate that was enlarged that reduces their ability to urinate like they're supposed to. And then the patient agrees with the procedure. Well, that is an example of readiness for enhanced urinary elimination. There you go. Boom. All right. Urinary incontinence, stress. Ooh, yeah, this always happens. So urinary incontinence, no stress incontinence versus overflow incontinence versus urge incontinence. There's one more dadgummit, and I always do this. Stress, overflow. Dadgummit, now I've got to look it up. I hate this. See? You guys always think I know everything. I don't. Types of urinary incontinence. See, I told you guys, we use our phones all the time. Anyone who says we don't, it's not accurate. I understand why they wouldn't want you to do it in the room, but still. Stress, urge, overflow, functional, mixed. Oh, come on. I had them all. That was it. Stress, urge, I said those two. Overflow, I said that one. Mixed incontinence. Oh, for the love of Pete and cheese. Oh, you know what? No, I'm giving that to myself. Points to Molly. Done. 5 points for Gryffindor. All right. So that's always the question that you get. No stress versus urge versus overflow. Just know it. Minor output. Oh, yeah. What is oliguria versus inuria? You need to know the difference in the two. Why do we avoid indwelling catheters? What do they cause? Well, they cause trauma and they cause increased risk for infection. So know that the second we put them in, we better put them out, right? From the moment we put them in, we're planning to get them out. All right, no output means a big problem. Yeah, for sure. If you don't have any output and that person is in a catheter, it's probably pinched. The catheter is internally pinched. So you have to move the patient around, and then you will get an outflow of urine, probably very fast. If they haven't peed in hours and they don't have a catheter, you need to put a catheter in. You need to straight cath them first. Intermittent is better than indwelling, because we want the smallest amount of infection risk possible. And if a person's been retaining urine, there's a lot of sediment in there, right? There's a lot of junk and funk in there. If things are not moving, it is just like anything else in the world. If you have stagnant water in a puddle, it is going to get algae on top of it. It's going to get toxic and infected because we don't have things that are moving along like a stream. That's active versus stagnant water. That's an active versus passive system. Things have to actively move in order to live and flourish, or things start to decay. I mean, you see it everywhere around you. And people say medicine's hard. It's not. You can appropriate it with anything that we do in everyday life. If you sit dishwater in the sink and leave it, it's going to be gross. If you keep that water at a very small free flow where you're pouring water in and you're exiting it out at the same time, that water will stay fresh. Duh. Okay? Same concept. That's it. Catheter-associated harm, what could happen? Well, they can get skin tears. They can get wounds, right? Because of the catheter-associated harm. UTI. All right, cool. Always have drainage bag below the bladder. Why? Well, because if we have it above, then it's backing into our bladder and it's causing our bladder to blow up. And our whole reason for having that catheter is to let the bladder chill on its own, which is the opposite of what we want to do. Plus, it interrogates the inner tissues of the bladder, and that sloshing around could also cause trauma and bleeding, right? Just throwing that out there. And it's icky. How about that? It's gross and icky. Can we say that? Is that a science? Is that a science thing? I just made it that way. Boom, done. Right? Routine catheter care. How often? It should be Q shift. It also should be more frequent than that. After a bowel movement, things of that nature. How do you clean the catheter? What direction do you go into? These are all things that come up. Maintain closed drainage system. What does that mean? What does that mean? How do you accidentally open the drainage system? How do you close it appropriately? And when we say drainage system, we usually mean drainage system from the tip of the bag. A lot of them have a cap that you clip in, and then you have to relieve that cap and pop it. And a lot of times, if you don't clip it just so, it's going to be leaky, right? That's the problem, because there is not a closed drainage system that is appropriately closed. There are also other definitions of closed drainage system that means things can go out but cannot burp back. They cannot regurgitate back. So I don't know exactly what that sentence means to you, but it's one of those two types of systems. So whatever type you talked about or went into, you need to know what that looks like. Perhaps maybe you're educating a patient and explaining to them what a closed drainage system means and why they shouldn't worry about, some type of something related to a urinary catheter, or related to a transurethral resection of the prostate, or what they call a TURP procedure, TURP. That's always a question. Change catheter every 4 to 6 weeks with long-term use. That is accurate. And then what, again, are the problems associated with long-term catheter use? Well, we start having trouble with balloons and urethras. We start having trouble with infection. So what type of education do we need to give our patient? How often should they be cleaning themselves? What direction should they be using concentric circles, towards the inside, towards the outside when they're cleaning, right? Should they clean from the top of the catheter to the bottom, or bottom to the top? That type of a deal. So I think that's exhausted everything in those areas. So let's jump to the next slide. All right, so when we're talking about advancing diets, it's always going to be going from clear to fulls. So like patient has been tolerating clear liquids, what could be introduced into a full diet for the patient's menu for lunch, right? And then we could say like coffee and cream, or we could say, I don't know, pudding, or we could say ice cream, right? Things of that nature. So that's usually how that looks. When it comes to patients and fetuses, first off, if it's the first time post-stroke, you have to stay with them. Keep the patient upright 90 degrees so that they don't aspirate if they start coughing. Get rid of that meal, put them on NPO, notify a physician, tell them to tuck in their chin and swallow, tell them to, they need to eat slowly, they need to have time to chew their food and swallow, and again, don't leave them alone. Parenteral nutrition, total parenteral nutrition, or TPN, is done intravenously through a central venous catheter, which has to be changed regularly, especially if there is bubbling of that dressing at all, because we don't want anything to penetrate and get into that area, right? Because that could be a problem. We do this through surgical asepsis so that we can't get this person septic. And we have to change the dressings every few days. So know what the dressing policy looks like for your examination. Is it every 3 days? It's usually every 3 days, or every Wednesday and Saturday for most hospital systems, or if it needs change because it's hurting the patient, or it's bloody, or there's drainage or anything like that. So know what that looks like for you. And then dietary restrictions based off religion. It's almost always a Muslim patient who cannot have any pork products or anything alcohol related. I've never seen an alcohol question specific to a Muslim patient, but I have seen pork a million times because we, give everyone and their mom heparin. And I have to tell 1,001 doctors they need to back off the heparin for patients who are Muslim. And I can't stress how aggravating that is to do that, because it's not like, it's not that big of a deal. It's a huge deal if you know anything about what that means. So make sure that if you don't, you're looking it up, because you should, right? To say that you're going to be a service to humanity means you need to understand humanity itself. So do it. Don't talk about it, be about it. So Ramadan, know what that looks like. So good, fasting from sunrise to sunset for a month. What does fasting look like for them? Look it up. Are they allowed to have anything? Because they can. I'm not going to tell you what it is, but during the day they can have something. So you need to see what it is that they can consume. But know that for the most part, they're not consuming anything. Also, Christianity and Hinduism, I don't really see a lot of that, but I would pay attention to it. I don't think I've ever seen a question related to Christianity and dietary preference, or Hindu, to be fair. But I would look at Hinduism because this is a religion that's been around, by the way, for thousands of years. Matter of fact, it's one of the first religions, if not the first religion, if I'm not mistaken. Well, I think I'm not lying on that one, but look it up. Been around for forever. So we need to be aware, because the Hindu community is up and coming in Ohio. So we need to get with it and understand it and celebrate it. Duh. So know these points. Know what that means for them. And I don't think I've ever seen anything related to it, but I would still, they're changing things so fast. They might throw something in there. So just know. And then we can just move on to the next slide. All right, cool. Church of Jesus Christ of Latter-day Saints, or Mormons. I don't think I have ever, I might be lying to you. I don't think I've seen a question about Mormons related to dietary preference, but yeah, no alcohol, no tobacco. Why would we ever do either of those things for them? And caffeine, such as teas, coffees, and sodas. So this would be more related to caffeine, if anything. Seventh-day Adventist. I have never seen a question about this person, ever. But I would know, just in case, if I'm honest. Know your full liquid. Know your dysphagia stages. Thickened, liquid, pureed. Know those things. Those will come up. Know high fiber. Like, what are those foods look like? Know your sodium requirements. Know how much cholesterol. Know what's on a diabetic diet. Know all of these diets. Know every single thing about these diets, period. Because one of these is going to come up. And then we can move to the next slide. All right, so parenteral nutrition used for non-functional GI tracts. Well, yeah, for sure. So parenteral nutrition is important for trauma to the abdomen, right? Because nothing's going to work. Severe malabsorption, sure. A lot of cancer patients have to deal with that as well. Who have just gotten so bad. Yeah, there it is. Chemotherapy, radiation therapy, bone marrow transplant, accurate. Know what types of patients, but more importantly, know that it's used for someone with a non-functional GI tract versus an enteral nutrition, which is used for someone with a functioning GI tract, right? So that would be for people who have fistulas or IBS. They can still eat because they might have hyperactive or hyporeactive responses, but they still have responses, period. And that's all they want you to know for this. So we can go to the next slide. All right, so health promotion, sensory altercations. Yeah, so this is a big one. They're going to ask you for your education. What would you tell these guys to do? And again, it's going to be exercise and muscle strengthening related to sensory altercations based off of musculoskeletal gait abnormality type of issues, more than likely. Establishing safe environments, yeah, due to sensory altercation. So that could be a blind patient, making sure that you move things free of cords, or for elderly patients with frequent falls, that would be another person like that. Removing any rugs in the room or any, slipped items, things of that nature. Oh, yeah, there it is. Hot water, cold water are big problems. You can adjust the water heater so that they don't get hurt. Making sure that you don't trip over cords, making sure that tables don't move, things like that. Communication boards, yes, for people who cannot speak. So that would be Broca's motor aphasia has been affected. And they do have that issue. So they would have a communication board to point to the things that they need. And a communication board is a picture of a bunch of faces that are doing actions like shout, and it says shout. And it's a picture of a person shouting with little lines that show that they are screaming, right? That type of a deal. And that way you can communicate with your patient versus a picture chart that lets you know sad, pain, hurt, ouch, that type of a deal. So you could use those charts to communicate. Sensory overload sucks. How about that? Just big fat sucks next to it. Can happen frequently in the hospital. Yeah, can happen frequently when going outside. How about that? Or being inside. Effective interventions, cluster care to reduce interruptions. Yes. I do not want you in my room dealing with your energy 15 times because you forgot 15 things, because not only is that clicking and clacking of that door coming in and out, I feel that gust of cold air that comes from the hallway into my room and sends a chill up my spine on top of it. And if you're pissed off because you've got 15 things going on, I get your pointed energy on top of it while you're clicking your pen, and all I can do is count them while you're asking me how many meds I take. All right, this is just a small experience, and I'm missing out a lot of pieces and parts that don't need to be added, because I think I showed you how crazy that brain is already, and that's just mine, right? That's just mine, and I am widely successful, and that is kind of what Spectrum looks like in a nutshell. So don't put a person in this position. It sucks so bad, and it's every day, and it never shuts off. There's not a switch. I swear it's the hardest thing in the world some days, and then other days is great, whatever. So dim the lights, cluster care, keep your noise down. And it's not even the noise. Sometimes it's somebody's voice. Sometimes I can't help it, right? Like somebody can talk really, really low, but if they have a voice that is very high pitched, it hurts. Dogs barking hurts. Not because a dog has a terrible voice, but because it's the pitch. It sounds like someone is crashing in my ears when I hear a dog barking, and it hits that top of the frequency. It feels like crushing, crumpling paper in my ear, and it physically induces pain into my ear. Like a physical jolt of lightning in my ear. I can't, I know it sounds nuts, just trust me, right? Keep the patient away from the nurse's station. Why? Because nurses don't shut up, that's why. All they want to do is talk about what they did over the weekend, because nurses want to live a normal life, and of all the jobs in the world, nursing is the one job where, a lot of bad things can happen in one day and nothing good happens. So that moment that you have with those people to laugh, that's a very cherished moment. But again, don't be a jerk, because this person can't handle all that cackling. And y'all cackle at 3 a.m. Don't act like you don't, because I used to be a night nurse. All right? I used to be the head of the cackling hens. So schedule rest periods as well. They need time to be away from you. It is energy vampires when you have to go into a room sometimes, because you just carry a different energy, and people, they're very receptive to it. And because you understand what you understand about the world around you in a little different way, a lot of people want to come to you and say, hey, I got these things going on, and that's cool, and I'm happy. And I love being that for all of you guys. I want to be that for all of you guys. My whole life is based on you, and I'm happy for that. And my kids, right? I'm happy for that. But I've got to have time to reboot and reload, right? Because when that battery gets depleted, I got to be alone or in the woods or away. So scheduling rest periods gives that outlet for these type of people who go into sensory overload to be able to rejolt their batteries so that they can be there for you again and be functional. So there's that. That's my 2 cents, and I'm sticking to it. So those items will probably be on the exam in some form, all those contingency points, or why. Next slide. All right, sensory alterations again, acute care. All right, cool. Controlling sensory stimuli, decrease environmental stimuli. Yep, keep noise down, bundle care, perfect. Considerations for neurological patients with sensory deficits. Yeah, pay attention to blood pressure. Prioritize interventions. Yeah, I'd say so. All right. Neurological patients with sensory deficits, blood pressure is going to tell us a lot about that patient. It could tell us a lot about pain too, and pain perception if they have deficits in their ability to speak or to communicate that they're in pain. If they have a high blood pressure, that's indicative of increased pain, right? Over a period of 2 hours. So the question might be, Sally who sells seashells by the seashore, who can no longer speak to a recent stroke, has had a fall and has broken their hip. And the patient is aphasic with dysphagia, so inability to, speak or swallow. How can we tell if something's wrong with this patient? Patient's blood pressure at 8 o'clock was, 130 over 80 when pain medication was given, and then 3 hours later it was 210 over 101. What could be indicating, or what could be the indicator for this patient's change in condition? Pain. Pain. Pain is the reason. Pain is the answer. So look at that and consider those things. Autonomic dysreflexia. Yes, it absolutely happens in a spinal cord patient. It does not receive messages at all. It's very sad. Know the signs and symptoms of autonomic dysreflexia. Know what it means. Know what it means for the patient. Okay, that'll be on there. Wide pulse pressure. What does wide pulse pressure mean? And when it keeps getting wider, what does that mean for the patient? You need to know that. That will be on there. That usually is on that question, or that usually is on this examination, if it's going to be on anyone. And the fact that it's in red is very suspicious as well. So I would know what causes a widening pulse pressure, and what does that mean for the patient, and what do we need to do to fix it. As long as you know those 3 things, you should be okay. Next slide. All right, so spiritual health, cool. Yes, use open-ended questions. But a lot of times your questions based off of this point is going to be knowing that you need to use open-ended questions, or needing to identify which question to use, and that will be your open-ended question is the answer, right? So like, can you describe how you're feeling today? Open-ended question. So you look for the one that isn't saying a yes or no answer, and that's your answer. Do include others, yeah, for sure. To learn more about spiritual preferences and how to adapt to your treatment to their preferences, yes. Keep in mind, diet practices and death practices are important, obviously. Okay. Okay, good. I like your example. Wash the body and wrap it in white cloth with the head turned to the right shoulder. Why? I know the answer why. Look up the answer why. And also, look up the why, but also look at position of body in relation to the sun, and see if that is also a factor. And that should be all I need to say about that. But yeah, that's a great example of death practices. Very good. And that's pretty much all you're going to get. So you're probably going to get 2 questions related to that. And again, because the Islamic patient is a little bit different as far as their religious practice. I would focus on this type of patient just because I don't see a lot. I'm trying to think. Because no Somali patients, nope, that wouldn't make a difference. Yeah, because they still, many of them practice Muslim religion. Okay. Yeah, yeah, that's right. Focus on that right there, and then that should be good enough. And then let's go to the next slide. All right, so when we're talking about this last slide, I need for you to understand that self-concept nursing, you need to know what self-concept nursing is. You need to know the terms related to self-concept. Role performance versus role overload, just give it a Google and know the difference in the two. Know about the stressors related to role overload as well. That usually shows up. Nurses' effect on patients' self-concept. Yeah, our ability to change their perception of everything around them is pretty serious. So we need to check ourselves. Meet clients' needs in a non-judgmental manner. Yeah, you better, right? He who is without sin cast the first stone. Buddy, I better not see a daggone rock in the air. You hear me? Not one. Not a one. Yikes. I wouldn't want to be that guy. That's all I gotta say. Yikes. Alright. So that'll definitely pop up. Nursing process assessment. Patient-centered care. Yeah, absolutely. There might be a question related to some family members being in a room while you're trying to deal with a patient who doesn't want the family to know what's going on or shouldn't, right? They might have something like, I don't know, AIDS. So our job is to kick them out. That's going to be the central message behind that. There might be a problem with a patient who is incapacitated. And there's several family members around. So we need to know who's the power of attorney. All right. There might be a concept where there's an altercation between a patient and their estranged spouse and the girlfriend's there. I've seen questions like that. So you just need to know, we need to find the healthcare power of attorney, whoever that is, or the next person in line legally. So unfortunately, in this case, it would be the wife who's legally married, not the girlfriend, right? If the patient's incapacitated, if he is not incapacitated, he can make that decision for himself, obviously. Use knowledge of developmental stages. Yes, so you need to know the different developmental stages of nursing process. You need to know the stages of self-concept nursing and the development of that. And then I think that's all you need to know about the mid-40s to mid-60s group as well. Yeah, all that looks really good. This is a really good slide. All right, let's see what we have over here. Nursing process, planning and outcome identification. Outcome should be focused to support on the patient's self-esteem. Yes, absolutely. We want their self-esteem to be as up in the air as possible. We want them to know things are going well, so we want them to reiterate those things that are going well, maybe not focusing on the things that aren't, playing the glad game, if you will. Encourage patients to be involved in their care decisions. Absolutely, that's the core of nursing process. That's what they call it, patient-centered care. Duh, right? So we want them to be involved in our care decisions. If you see a question that's what I call like a basic question, or a dry, starchy question, when I see these questions, it's like, what do we need to do to continue our nursing process in a good fashion, right? And that's when we come up with these, encourage patients to be involved in their care decisions. It's one of those things where it doesn't take a lot of thought process, but it can be very tricky because the technical answer of why we do what we do is usually not discussed. It's just kind of implied, so we never really think about the why behind what we do. and why we do what we do. So it jogs our brains back into thinking on a very basic level, and sometimes can get very confusing because of that, because we're so far advanced in our way of thinking as a nurse, like we're not thinking about why we do what we do at that point. So when we go back to these, we usually just look at the one that sounds the prettiest and the widest and the brightest and the freshest smelling of the answers, and that usually is good. Using communication skills, obviously, to clarify patient and family expectations. Taking the patient's needs first, obviously, because the patient's our patient, not the family. That type of a deal. Again, it might also include excusing family members from the room, and being insistent on they have to leave because, we're going to violate HIPAA. HIPAA is also one that pops up often on this question or on this examination, so that might come up as well. Who should we tell? Who shouldn't we tell? That type of a deal. So I hope that this helped you. I hope that this kind of clarified things a little bit more. I gave you as much information I could as of what type of things we need to focus on related to these topics. If you need any clarification, let me know. I hope that this is going to be beneficial to you. Let me know how the test goes. I'm excited for you. I think it's going to go really well. I think if nothing more, just studying the way you study and preparing your slides, how you've been preparing your slides and working as a group is going to make a big difference. So I hope to hear some good things. So I love you guys. I'm proud of you all very much. And I know you're going to do great. So call me and let me know how it goes. Okay, bye.